Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I would like to thank the organizing committee for inviting me to present today. My presentation, is it food allergy or food intolerance? This is a common burden that face any physician. The aim of my presentation today is to define symptoms that are consistent with IgE food allergy, to define symptoms that are non-IgE or related to food intolerance. Then we will review some tests and how to diagnose. Finally, I may mention some concrete example of both conditions. By definition, food allergy is an immunological reaction that involves type 1 hypersensitivity. It is mainly an IgE antibody mediated. While food intolerance is a spectrum, it may involve immunological reaction, biochemical, pharmacological, or even direct toxicity of a food product. Why we need to differentiate between food allergy and food intolerance? First, the natural history. In food allergy, there is consistency of certain symptom. Every time you're exposed to that food, you will develop a rapid symptom. Another reason is anaphylaxis risk, which is only exists with food allergy. And I believe this is enough reason to differentiate between both conditions, simply because anaphylaxis can lead to death. It is only exists with IgE-mediated food allergy. As I mentioned, the food allergy is IgE-mediated. It is reproducible. There is consistency, as I mentioned, of symptom. Second, it is multi-system. Certain allergy associated with frequent resolution, like milk and eggs. When we say milk, we mean cow's milk. When we say eggs, we mean hen's egg. What it means, most children, they lose their allergy to milk. About, I can say, 70 to 80%, they outgrow of it, while 60 to 70% will outgrow of it. On the other hand, the nuts, peanuts, and fish, which mainly affect adults, only 10 to 20% lose their allergy with time. More than 170 food have been reported to cause IgE allergy. So this is the self-reported or patient reporting. Actually, only 6% of children have food allergy, and only 3.5% of adults have real allergy. In kids, milk, eggs, soya, wheat, and peanut, this is the most common allergen. While in adults, crustacean like shrimp, lobster, crab, tree nuts like almond, peanuts, and fish are the commonest. I rate it here from the commonest to the lowest prevalence. As I mentioned, there is a discrepancy between the self-reporting food allergy and what is confirmed. As you see here, in children, parents claim that about 6 to 5% of their children have milk allergy. But in reality, less than 1% have milk allergy. It's similar. And this is the role of the physician to confirm the diagnosis. Because if you say your kid is allergic to milk and egg, what he will eat? He may have malnutrition. The food intolerance, there is variability. Not every time you're exposed to food or you take the food you will have the symptom. Sometimes you need to take it for a long time to develop symptoms. Sometimes person need to take large amount of food to develop symptom. Usually affect one system. We come to the symptom. Cutaneous is the most common. As you see here, this is the allergy, the IG mediated, and here the intolerance. Pruritus and erythema can exist in both, but urticaria and angioedema is only typically occur with the allergy. The gastrointestinal symptom, angioedema of the lips, tongue and palate, pruritus, nausea, abdominal pain, vomiting, diarrhea. While on intolerance, it is reflux, as mentioned in the previous presentation, bloody diarrhea, constipation, and pallor, tiredness, sometimes failure to thrive. Fluttering of breath is a symptom of food intolerance. Respiratory, the upper respiratory occur only with allergy, while the lower respiratory, it can occur with both. This is the mechanism of IgE-mediated food allergy. As you see here, the mast cell recognize the allergen as a foreign body, and it is attached through the IgE antibody to the mast cell. This leads to degranulation of the mast cell, which release chemicals. Not only histamine, some vasoactive substance, some leukotrienes. And this may explain that why antihistamine alone will not work, because you have another mediator. This symptom I mentioned, not every patient will have all these symptoms. He may have only cutaneous symptom. He may have GI, and not every time may have the same symptom. How to diagnose food allergy? History is very important. You need to take detailed history, the timing, the symptom, reproducibility. Sometimes you need to ask the patient to have a food diary to detect the symptom. Typically, the patient can list his common food. Then every 2 weeks he removes some of it until he can recognize that offending food. The second test is, or the gold standard is the skin prick test. What we do, simply we take extract or sometimes the real food, and we make a superficial prick on the skin and put the allergen, and we observe it for about 15-20 minutes. The positive test when develop erythema or wheals on the skin. It is non-expensive, easy to be done, safe. There is no systemic symptom. Usually done by allergist. It is not that specificity about 50 to 60%, but it is highly sensitive, more than 95%. What it means, when it is negative, it excludes the food allergy. But still, history is more important, but it is for confirmation. Sometimes we need to do, for non-IgE, biopsy can be done, like for celiac disease or dermatitis associated with celiac, we can do skin biopsy. For lactose, there is specific test like for lactose intolerance or cystic fibrosis. Endoscopy can be done to exclude, because patient came to us with symptom, not a diagnosis. Endoscopy is important for detect ulcer, the sign of Crohn's, or sometimes to take a biopsy. There is many tests, but none are evidence-based, like gastric juice analysis, electrodermal test, kinesiology, which is test the muscle response, hair analysis. All is not recommended. If in the serum specific IgE is not recommended by guideline, all guidelines say don't use it for diagnosis. But we use it in our hospital, and many use it to monitor, to make it more confirmed, but alone should not be used for confirming the allergy. We will come to some concrete example. There is what's called oral allergy syndrome. It is the most common food allergy condition associated with oral pruritus. Rapid onset, it is IgE mediated, but rarely cause a systemic symptom. This disease occurs only in patients with allergic rhinitis or atopic asthma. The interesting thing about it is that the patient is allergic to these airborne allergen. If he is allergic to any of this that causes his allergic rhinitis, when he eats this food, he will develop allergy. And usually these patients, they have high IgE in their blood. This is one mentioned in the previous presentation about eosinophilic esophagitis. It is type of food intolerance. Another example of food intolerance condition is celiac disease, as you know. Dermatitis herpetiformis, it is a skin condition characterized by vesicular pruritic eruption, mainly in lower limb and abdomen. It occurs only with patients with celiac disease. And the treatment is to treat celiac disease. If celiac treated, it will disappear. Lactose intolerance is a well-known food intolerance due to the deficiency of lactase enzyme. Infantile colic is a common condition also, poorly defined. And there is no evidence that it is related to food hypersensitivity. And as I mentioned, many parents and they think that their kids are allergic to food, to milk or to egg. And as I mentioned, if the child not taking egg and milk, this may affect his nutrition and his health. Food poisoning from staph or salmonella, patient, he may believe simply that it is related to allergy. Peanut allergy, as I mentioned, it is one of the most common food allergen. It is associated with a large number of severe reactions. Awareness is increasing to this allergy. It can lead to death. Real prevalence is unknown, but it is increasing. The prevalence in North America, it was 21 per 100,000 on the period between 1983 and 1987. It jumped to about 50 per 100,000 on between 19 and 2010. Allergy is mainly due to the protein, by definition. So the taste and the smell of peanut is not allergic because it came from the lipid fraction. The peanut dust used in airplane can cause allergy, but a patient who is allergic to peanut can work in a shop and he can sell peanut. We come finally to anaphylaxis, which is one of the clinical manifestation of food allergy. As I mentioned, it only occurs with IgE food allergy. It is usually multi-system, acute onset. It can be mild. It can lead to death. Any food theoretically can cause anaphylaxis. As I mentioned, peanut and tree nut is the commonly associated with severe anaphylaxis. The symptom, usually multi-system. It can cause abdominal pain, diarrhea, angioedema, flushing, urticaria, chest tightness, cough, wheezing, feel of impending death. It leads to hypotension, rhinorrhea, or even uterine contraction. The risk for anaphylaxis increases with patients with underlying asthma, especially untreated, delayed epinephrine, previous severe reaction. There is what's called biphasic reaction. I will come to it. The risk of death from anaphylaxis increases if there is hypotension, bradycardia, bronchospasm, or there is poor response to epinephrine injection. Patients who already have Addison disease, coronary artery disease, asthma, and adolescent all increase with the risk of death. How to manage anaphylaxis? It is very important. The main treatment is intramuscular epinephrine, adrenaline. This is the main treatment. You can add intramuscular diphenhydramine, steroid, and Zantac can be added. IV fluid if there is hypotension, oxygen if there is bronchospasm. But the main thing is the adrenaline. Here I have a video to show how to use. I don't know how to.
Using your EpiPen is easy. First, remove it from the plastic tube. Now, swing and jab the EpiPen firmly at a 90-degree angle into your thigh. You must seek medical attention. Call 911 immediately, or have someone else take you to an emergency room as soon as possible. Remember to take your used EpiPen with you, and be sure to give it to your physician for inspection. For more information about EpiPen, visit our website at www.epipen.com.
I will repeat it.
The first step in being prepared for a severe allergic reaction, also called anaphylaxis, is having an EpiPen on hand at all times. Using your EpiPen is easy. First, remove it from the plastic tube. Now, swing and jab the EpiPen firmly at a 90-degree angle into your thigh. You must seek medical attention. Call 911 immediately, or have someone else take you to an emergency room as soon as possible. Remember to take your used EpiPen with you, and be sure to give it to your physician for inspection. For more information about EpiPen, visit our website at www.epipen.com.
Okay. I finished. This is the last slide. Before I finish, I want just to mention the role of family physician. The video we saw is how to use epinephrine, and I believe every patient have food allergy. He carry the risk of anaphylaxis, and he should have EpiPen with him, and how to use it. Our role as a family physician is not only to detect and diagnose patient with food allergy, but also to refer for confirmation to allergist, to educate the parent and the patient, to provide them with, make sure they are provided with EpiPen, and to explain to the parent how to use it simply because it saves life. Also, you can contact the school and make sure there is, in North America they keep 2 for every kids with allergy, 1 at home and 1 at school, and they make sure there is not necessarily nurse or anyone can use it. As you saw in the video, it is very easy to use, and to keep a record of these kids and to make sure that they check their expiry date and to provide them with all information. Thank you very much.